The nasal structures begin their complex development during week 4 of gestation, when the nasal placodes appear as bilateral thickenings on the frontonasal prominence. These placodes represent the earliest indication of future nasal development, and their proper formation sets the stage for everything that follows. By weeks 5 to 6, these placodes invaginate to form nasal pits that gradually deepen, creating the primitive nasal cavities that will eventually connect the external nares to the nasopharynx. Week 7 marks a critical milestone when the oronasal membrane ruptures, establishing communication between the nasal cavity and the primitive oral cavity. This rupture creates the primitive choanine. If this process fails, we see choanal atresia, a condition you'll encounter in the delivery room. The nasal septum begins forming during weeks 9 to 10, dividing the single nasal cavity into 2 passages. By week 12, the choanae should be fully patent, allowing normal nasal breathing that newborns depend upon as obligate nasal breathers. Understanding this timeline helps predict when teratogenic insults cause specific malformations. Early disruptions affect basic structure formation, while later insults impact septation and patency. Choanal atresia results from failure of the oronasal membrane to rupture or from abnormal mesenchymal proliferation blocking the posterior nares. This embryologic basis explains why choanal atresia often occurs with other midline defects and why bilateral cases present as airway emergencies at delivery. Choanal atresia represents complete obstruction between the nasal cavity and nasopharynx, occurring when the posterior choanae fail to canalize during embryologic development. With an incidence of 1 in 5 to 8,000 births, this condition shows a 2-to-1 female predominance for reasons that remain unclear. Unilateral atresia occurs twice as often as bilateral, a fortunate distribution since bilateral cases present as life-threatening airway emergencies, while unilateral cases may go undetected for months or years. The obstruction itself is bony in 90% of cases, with only 10% being purely membranous. This distinction matters surgically. Bony atresia requires drilling and creates more challenging repairs with higher failure rates than membranous obstructions. The atretic plate typically measures 2 to 7 millimeters thick, with thicker plates correlating with more difficult surgical repairs and higher restenosis rates. Half of affected infants have associated anomalies, making choanal atresia a potential marker for broader developmental issues. Charge syndrome represents the most common association, with choanal atresia being the A in the acronym. Other associations include craniofacial anomalies, cardiac defects, and various genetic syndromes. This high rate of associated anomalies mandates comprehensive evaluation beyond just addressing the airway obstruction, particularly looking for features of charge syndrome, which significantly impacts long-term prognosis. Bilateral choanal atresia creates an immediate airway emergency in the delivery room that demands instant recognition and intervention. Newborns are obligate nasal breathers for the first several months of life. Their larynx sits high, the epiglottis nearly touches the soft palate, and they lack the neurologic maturity to coordinate mouth breathing when nasal passages are blocked. With both posterior choanae obstructed, these infants cannot move air through their preferred nasal route, creating a paradoxical presentation that's pathognomonic once recognized. The classic cyclic cyanosis pattern provides the diagnostic clue. Infants turn pink and vigorous when crying because crying forces mouth breathing, but become cyanotic and distressed as soon as they quiet down and attempt nasal breathing. This pink when crying, blue when quiet cycle repeats endlessly until the airway is secured. Parents and nurses often notice the infant seems fine when agitated, but deteriorates with calm, the opposite of what we'd expect with most respiratory conditions. Unilateral choanal atresia presents entirely differently, often escaping detection for months or years. These infants breathe adequately through one nostril, though they may demonstrate subtle feeding difficulties from inability to coordinate breathing and sucking effectively. The classic presentation is persistent unilateral rhinorrhea, clear discharge from the affected side that never resolves despite multiple courses of antibiotics for presumed sinusitis. Only when someone attempts to suction that nostril or specifically tests nasal patency does the diagnosis become apparent. The diagnosis of choanal atresia begins with clinical suspicion confirmed through simple bedside tests. Inability to pass a 6 French catheter through the nares provides the first objective evidence. The catheter meets firm resistance rather than passing smoothly into the nasopharynx. This test requires gentle technique to avoid creating a false passage through traumatized mucosa. Another bedside confirmation involves instilling saline drops into the affected nostril. Absence of swallowing or coughing indicates the fluid cannot reach the pharynx, pooling instead in the blocked nasal cavity. CT scanning serves as the gold standard for definitive diagnosis and surgical planning. High-resolution CT precisely defines whether the atretic plate is bony, membranous, or mixed. Critical information since bony plates require drilling, while membranous obstructions might yield to dilation. The scan measures atretic plate thickness, with thicker plates predicting more difficult surgery and higher restenosis rates. CT also reveals the width of the posterior nasal cavity and any associated abnormalities like nasal cavity hypoplasia that complicate repair. Flexible endoscopy adds valuable information when available, allowing direct visualization of the atretic plate from both nasal and pharyngeal approaches. This helps confirm bilateral involvement and assess for other airway anomalies that might complicate management. The combination of clinical findings, imaging, and endoscopy provides the comprehensive assessment needed to plan optimal surgical timing and approach, while identifying infants who need evaluation for associated syndromes. Managing bilateral choanal atresia requires immediate airway stabilization using techniques that bypass the obstructed nasal passages. An oral airway provides the quickest solution, maintaining tongue position to keep the oral breathing route patent. The McGovern nipple, a modified nipple with the end cut off, serves as an improvised oral airway that infants often tolerate better than rigid airways. These temporizing measures work because they prevent the tongue from obstructing the oral airway and remind the infant to breathe through the mouth. Prone positioning alone is inadequate and dangerous. While it may help keep the tongue forward, it doesn't address the fundamental problem of obligate nasal breathing. Surgical timing depends entirely on laterality. Bilateral atresia requires repair within the first week of life to establish normal nasal breathing and allow safe feeding. Modern endoscopic techniques have largely replaced traditional transpalatal approaches, offering better visualization with less morbidity. Unilateral atresia allows elective timing, since adequate ventilation occurs through the patent side. Many surgeons delay repair for months or even years until the nasal passages are larger and surgical success rates improve. The major challenge remains restenosis, occurring in 30 to 50% of cases, regardless of surgical technique. The narrow posterior nasal cavity in these infants predisposes to scarring and progressive stenosis after initial successful repair. Most surgeons place temporary stents and prescribe prolonged nasal steroids, though optimal protocols remain debated. Parents need counseling about the likelihood of revision procedures and the importance of close follow-up to detect early restenosis when dilation might prevent complete reobstruction. Charge syndrome represents the most important association with choanal atresia, with 50 to 60% of charge patients having choanal involvement. This makes choanal atresia a major diagnostic criterion for charge, and conversely, makes charge evaluation essential for any infant presenting with choanal atresia. The acronym itself highlights the cardinal features: coloboma, heart defects, atresia of the choani, retarded growth and development, genital hypoplasia, and ear anomalies including deafness. The clinical significance extends beyond just recognizing the association. When you diagnose choanal atresia, you're potentially uncovering a multisystem syndrome that dramatically impacts prognosis and management. Colobomas may threaten vision, cardiac defects might require urgent intervention, and ear anomalies almost universally cause hearing impairment. The genital hypoplasia can signal hypogonadotropic hypogonadism, requiring hormone replacement at puberty. Growth retardation affects both prenatal and postnatal development, often requiring growth hormone therapy. Every infant with choanal atresia warrants systematic evaluation for charge features. This includes ophthalmologic examination for colobomas, cardiac echo for structural defects, hearing assessment, and careful genital examination. The temporal bone abnormalities seen in charge are virtually pathognomonic. Absent semicircular canals on imaging strongly suggest the diagnosis, even when other features remain subtle. Missing this diagnosis means missing opportunities for early intervention across multiple organ systems, making thorough evaluation non-negotiable. Nasal septum deviation in newborns commonly results from intrauterine positioning, where prolonged pressure against the maternal pelvis or siblings in multiple gestations can compress and displace the cartilaginous septum. Traumatic delivery, particularly with prolonged labor, occiput posterior positioning, or instrumental delivery, significantly increases the risk of septal displacement. The cartilaginous neonatal septum remains quite malleable, making it susceptible to deformation but also capable of spontaneous correction in most cases. The presentation varies from incidental findings to significant functional impairment. Many infants show mild deviation that causes no symptoms and escapes notice. More significant deviations produce characteristic clinical signs. Feeding difficulties arise when nasal obstruction prevents coordinated breathing during sucking, leading to frequent interruptions and poor feeding efficiency. Parents often report noisy breathing, particularly during sleep, as air turbulence through the narrowed passage creates audible sounds. A particularly telling sign is strong preference for one breast during feeding. The infant positions to keep the patent nostril unobstructed. The key clinical judgment involves distinguishing deviations that will self-correct from those requiring intervention. Most septal deviations improve dramatically within days to weeks as the cartilage gradually returns to midline position. The combination of reduced external pressure and the infant's growth typically resolves mild to moderate deviations without intervention. However, complete obstruction of one nostril or deviations causing cyanosis during feeding warrant closer evaluation and possible early reduction. Management of neonatal septal deviation requires careful assessment, balancing the natural tendency towards spontaneous resolution against the risks of persistent obstruction. Observation remains appropriate for most mild deviations that don't significantly impair breathing or feeding. Serial examinations over the first week often demonstrate progressive improvement as the malleable cartilage gradually straightens. Parents need reassurance that the dramatic appearance often belies a benign course, with most deviations resolving completely without intervention. Early reduction becomes necessary when functional impairment threatens the infant's well-being. Stridor indicates significant airway compromise requiring prompt correction. Cyanosis during feeding represents another clear indication. Infants who cannot maintain oxygenation while feeding face both immediate hypoxia and longer-term failure to thrive. Complete nasal obstruction, even if the infant compensates through mouth breathing, warrants reduction to restore normal nasal airflow patterns and prevent obligate mouth breathing habits. The reduction technique requires gentle skill rather than force. After adequate preparation and positioning, gentle sustained midline pressure usually suffices to reposition the septum. Some practitioners advocate for soft silastic splints maintained for 3 to 7 days to prevent recurrence, though this remains controversial. Critics argue that splints risk pressure necrosis and infection while providing minimal benefit over natural healing. The lack of consensus reflects the reality that most deviations resolve regardless of intervention, making it difficult to prove any technique's superiority. The key is recognizing the small subset requiring reduction while avoiding unnecessary procedures in infants destined for spontaneous resolution. The ear's embryologic complexity stems from its triple origin, with external, middle, and inner ear structures developing from completely different primordia on different timelines. The inner ear begins earliest, arising from the otic placode during week 3, before many women even know they're pregnant. This early start reflects the inner ear's complexity, as it must form the intricate cochlear spirals and semicircular canals by week 20. This extended development period creates a long window of vulnerability for sensorineural hearing loss from various insults. The external ear develops from 6 mesenchymal proliferations called the hillocks of His, arising from the first and second branchial arches during week 5. These hillocks gradually merge and reshape to form the auricle's complex contours. Malformations here often signal broader first and second arch abnormalities, making auricular anomalies important markers for associated conditions like Treacher-Collins or Golden Haar syndrome. The middle ear cavity derives from the first pharyngeal pouch, while the ossicles form from neural crest cells migrating into the first and second arch cartilages. This complex embryologic origin explains the wide spectrum of congenital ear anomalies and their frequent association with other malformations. External ear anomalies often accompany middle ear abnormalities since they share branchial arch origins. However, inner ear malformations can occur in isolation due to its separate embryologic origin. Understanding these relationships helps guide evaluation. External ear anomalies warrant hearing assessment and renal ultrasound, while isolated sensor and neural hearing loss requires different workup focusing on genetic and infectious causes. When we examine a newborn's ears in the NICU, distinguishing between deformations and malformations guides both our counseling and management decisions. Deformations account for about 70% of ear abnormalities we see. These occur when normal cartilage gets compressed or positioned abnormally. Think of how a baby-positioned breech might have ears folded from pressure against the uterine wall. The cartilage itself is perfectly normal, just shaped differently. You'll see prominent ears that stick out or lop ears that fold over. The exciting part? These often respond beautifully to early molding. Malformations are fundamentally different. Here we're dealing with absent or underdeveloped cartilage and skin structures. These babies will need surgical reconstruction down the line, typically starting around age 6 when the ear reaches adult size. The critical distinction for your exam and practice. Malformations frequently come with conductive hearing loss because the external auditory canal often didn't form properly either. When you identify a malformation, your next move is always ordering that hearing screen and audiology follow-up. Microtia classification follows a straightforward grading system that correlates with both surgical planning and associated anomalies. Grade 1 presents as a slightly small ear with all normal structures present. Parents might not even notice until you point it out. Grade 2 shows a partially formed ear where you can still identify some normal landmarks like the helix or lobule. Grade 3, our most common presentation, appears as a rudimentary structure often described as peanut-shaped, essentially a vertical ridge of tissue with minimal recognizable ear anatomy. Grade 4 represents complete absence or anotia. Here's what matters clinically. As the grade increases, so does the likelihood of canal atresia and significant hearing impairment. About 60% of microtia cases occur in isolation, but that leaves 40% as part of syndromes. When you see microtia, especially grade 3 or 4, your assessment expands beyond the ear. Think craniofacial syndromes, particularly hemifacial microsomia, and always check for renal anomalies. The syndromic associations make comprehensive evaluation essential. This isn't just about the ear. Microtia presents unilaterally in 90% of cases, more commonly affecting the right ear, a pattern you'll notice consistently in practice. Beyond the visible anomaly, several associated findings drive our clinical management. Conductive hearing loss occurs frequently due to external auditory canal atresia. Since these babies can't get sound waves to their inner ear through the normal pathway, early audiologic evaluation becomes crucial for language development planning. Facial nerve anomalies may accompany microtia because the nerve travels through the same developmental structures. During your initial assessment, check facial symmetry with crying. Renal anomalies appear often enough that we routinely order renal ultrasounds. The ears and kidneys develop during the same embryologic timeframe, so when one system has issues, we check the other. Hemifacial microsomia represents the most common associated syndrome. You'll notice a symmetry of the entire affected side. Smaller jaw, possible cleft, and soft tissue deficiency. These findings together paint a picture that helps families understand this isn't just cosmetic, but requires coordinated care involving audiology, plastic surgery, and often nephrology. Timing is everything with ear molding. Those first 2 weeks after birth represent our golden window when maternal estrogen keeps cartilage remarkably malleable. Start molding within this time frame and success rates exceed 90%. Wait until 1 month and you've missed your opportunity. The cartilage firms up and won't respond to external shaping. Commercial molding devices work by applying gentle, continuous pressure to reshape the ear over 4 to 6 weeks. Parents need realistic expectations. We're treating deformations only. That baby with grade 3 microtia won't benefit because there's no normal cartilage to reshape. During treatment, watch for skin breakdown under the device, the most common complication we manage. The beauty of early molding lies in avoiding surgery later. A prominent ear that might require otoplasty at age 5 can achieve normal configuration with 6 weeks of molding as a newborn. When counseling families, emphasize this narrow window. Many parents want to wait and see, but with ear deformations, waiting means missing the chance for non-surgical correction. Universal newborn hearing screening represents one of public health's major successes, now mandated across all 50 states. The timeline matters here. Identify hearing loss by 3 months. Start intervention by 6 months. This early intervention window directly correlates with language development outcomes. Babies who receive amplification or cochlear implants before 6 months develop language skills comparable to their hearing peers. 2 screening methods dominate NICU practice. Otoacoustic emissions measure the cochlea's response to sound, quick, non-invasive, but can't assess the auditory nerve pathway. Automated auditory brainstem response tests the entire auditory system from cochlea through brainstem. Most units use a 2-stage protocol, OAE first, then AABR for those who don't pass. In the NICU, we often skip straight to AABR since our babies have higher risk factors and more ambient noise interference. With 98% of newborns screened nationally, we catch most hearing loss cases early, but screening is just step 1. The real challenge? Ensuring families complete follow-up testing when babies don't pass. Document your counseling carefully. Families need to understand that refer doesn't mean their baby is deaf, but missing that follow-up appointment could mean missing critical intervention timing. Universal newborn hearing screening represents one of public health's major successes, now mandated across all 50 states. The timeline matters here. Identify hearing loss by 3 months. Start intervention by 6 months. This early intervention window directly correlates with language development outcomes. Babies who receive amplification or cochlear implants before 6 months develop language skills comparable to their hearing peers. 2 screening methods dominate NICU practice. Otoacoustic emissions measure the cochlea's response to sound, quick, non-invasive, but can't assess the auditory nerve pathway. Automated auditory brainstem response tests the entire auditory system from cochlea through brainstem. Most units use a 2-stage protocol, OAE first, then AABR for those who don't pass. In the NICU, we often skip straight to AABR since our babies have higher risk factors and more ambient noise interference. With 98% of newborns screened nationally, we catch most hearing loss cases early, but screening is just step 1. The real challenge? Ensuring families complete follow-up testing when babies don't pass. Document your counseling carefully. Families need to understand that refer doesn't mean their baby is deaf, but missing that follow-up appointment could mean missing critical intervention timing. ECMO tops our risk factor list. The combination of high-frequency oscillation, ototoxic medications, and potential carotid artery ligation creates a perfect storm for hearing damage. Every ECMO survivor needs comprehensive audiologic follow-up beyond newborn screening. Ototoxic medications become concerning after 5 days of exposure. Gentamicin, tobramycin, furosemide, medications we use daily in the NICU. The risk compounds with concurrent kidney dysfunction since reduced clearance increases ototoxic exposure. Track cumulative days carefully and consider drug levels when courses extend. Hyperbilirubinemia, requiring exchange transfusion, specifically damages the auditory nerve through kernicterus. Even with successful treatment, these babies need serial hearing assessments through early childhood, as auditory neuropathy can manifest later. Torch infections, particularly CMV, cause progressive hearing loss. A baby might pass initial screening, then develop significant impairment by age 2. Severe birth asphyxia and bacterial meningitis damage hearing through direct neural injury and inflammatory cascades. Mechanical ventilation beyond 5 days correlates with hearing loss, likely reflecting overall illness severity plus noise exposure. When multiple risk factors combine, hearing loss risk increases exponentially. Document all risk factors meticulously. This information guides both immediate screening protocols and long-term audiologic surveillance. Congenital CMV stands as the leading non-genetic cause of sensory neural hearing loss in children, making it a critical diagnosis to consider in every NICU graduate with hearing concerns. Among babies with symptomatic CMV infection at birth, those with growth restriction, hepatosplenomegaly, or intracranial calcifications, 30 to 65% will develop sensory neural hearing loss. Even seemingly unaffected babies aren't spared. 10% of asymptomatic congenital CMV cases develop hearing loss. The progressive nature of CMV-related hearing loss sets it apart. A baby might pass newborn screening, then show moderate loss at 6 months, progressing to profound deafness by age 2. This progression drives our surveillance protocol. These children need audiologic monitoring every 3 to 6 months through age 3, even with normal initial screens. Antiviral therapy with valganciclovir shows promise when started before 1 month of age. Recent studies demonstrate not just halted progression, but actual hearing improvement in some treated infants. The catch? You must confirm congenital infection, CMV in urine or saliva within the first 3 weeks of life. After that window, you can't distinguish congenital from postnatal infection. When you suspect CMV-related hearing loss, time matters for both diagnosis and treatment decisions. Auditory neuropathy spectrum disorder presents a diagnostic puzzle that challenges our traditional understanding of hearing loss. These babies show normal otoacoustic emissions. The cochlea responds perfectly to sound, yet automated ABR testing reveals abnormal or absent waveforms. The problem lies in dysynchronous nerve transmission. Sound gets detected, but the signal to the brain arrives jumbled or delayed. NICU graduates face disproportionate risk for auditory neuropathy. Extreme prematurity disrupts myelination of auditory pathways. Hyperbilirubinemia, even at levels below exchange threshold, preferentially damages the auditory nerve nuclei. Hypoxic events compound the injury. When these factors combine in a 20S weaker with severe jaundice, auditory neuropathy risk soars. The variable outcomes make counseling challenging. Some children develop near-normal speech with amplification. Others show no benefit from hearing aids because amplifying a garbled signal doesn't improve clarity. Some even show spontaneous improvement as myelination matures. This variability means these families need close developmental monitoring and flexible intervention plans. Cochlear implants may help when hearing aids fail, but timing remains controversial. Document risk factors carefully. They guide both immediate management and help families understand the uncertain prognosis inherent to this diagnosis. When a baby fails their initial hearing screen, debris or fluid in the ear canal causes most first-time failures. Approximately 90% of babies who fail initial screening pass when retested. Always attempt a repeat screen before discharge, ideally waiting 24 to 48 hours for any canal fluid to clear. This simple retest prevents unnecessary parental anxiety and reduces the burden on follow-up services. For persistent screening failures, the clock starts ticking toward that 3-month diagnostic deadline. Schedule comprehensive diagnostic ABR testing. This requires sedation and takes 2 to 3 hours, but definitively establishes hearing thresholds. Family counseling begins immediately. Parents need to understand that refer doesn't equal deaf, but also grasp the importance of follow-up. Connect families with early intervention services even before diagnostic confirmation. These programs provide support and can start teaching communication strategies. The medical evaluation runs parallel to audiologic workup. Send CMV testing if not already done. Remember, only valid in the first 3 weeks of life. Consider genetic testing, as connexin mutations cause 50% of non-syndromic hearing loss. Temporal bone imaging may reveal cochlear anomalies. Schedule ophthalmology evaluation since many syndromes affect both hearing and vision. This comprehensive approach identifies treatable causes while building the support network these families need. Bilateral conal atresia represents a true neonatal airway emergency. These babies cannot breathe through their nose and struggle with feeding and breathing simultaneously. Your first clue comes when you cannot pass a suction catheter through the nares. Any resistance to catheter passage should trigger immediate evaluation for choanal atresia. Place an oral airway and prepare for definitive surgical management. The ear examination extends beyond appearance. Malformations, particularly high-grade Microtia, frequently accompany hearing loss due to canal atresia. These structural anomalies signal the need for comprehensive audiologic assessment beyond standard screening. Remember that early ear molding works only for deformations with normal cartilage. True malformations require surgical reconstruction. Every NICU graduate needs hearing screening before discharge, but our population requires heightened vigilance. With hearing loss affecting 2 to 4% of NICU graduates versus 0.2% of well babies, we cannot afford missed diagnoses. The mantra remains: identify by 3 months, intervene by 6 months. This timeline represents the critical window for normal language development. Document all risk factors meticulously. They determine not just immediate screening needs, but long-term audiologic surveillance requirements. Early identification and intervention transform outcomes, turning potential disability into typical development.